Thank you, Eduardo. Now go sit over there. Good morning, everyone. Thank you for being here. It's definitely an honor to follow Eduardo on the podium. As part of continuing to connect the problems to the solutions here in our community, it's also an honor to introduce our panel. And our panel consists closest to me of Kathleen Angel, who's Executive Director for Global Benefits and Mobility for Dell Incorporated, then Mr. Ali Khataw, who's President of Encotech Engineering Consultants, followed by the Honorable Ronnie McDonald, the County Judge from Bastrop County, then my friend and collaborator in the Children's Optimal Health Project, Susan Dawson, who's the President and CEO of the E3 Alliance, and then we have the great pleasure of having Eduardo continue on the panel. When I agreed to moderate this, now I have to figure out okay, someone's going to have to. Yeah, but I'm not sure which direction I'm going, because I've got, you want it here if you want to. That's what I thought. No, it's okay. If I can get to the next one, let's see if it works. Okay, that's fine. It's minus the burnt orange, which is how I sent it over. So I didn't quite recognize it, but that's okay. So as part of agreeing to moderate this, I thought I'd just turn to the panel and start asking questions, but the conference organizers asked me to set the stage by explaining to all of you national healthcare reform. And they asked me to do it in 5 minutes. And I said, sure. Because back in 1993, I worked in the Clinton White House on Clinton reform, and I remember a cartoon that was in I think the New Yorker shortly thereafter, and it asked, which claim would you be more likely to make in your lifetime? And claim one was, yes, I can teach a rhinoceros to play Beethoven on the harmonica. And claim two was, why, yes, I understand all the details of all the healthcare reform plans, and I'd be happy to explain them to you. Well, unfortunately, I was in category 2 even back then. So these stripped down, these are actually the first 5 titles of the table of contents of the Affordable Care Act. Now, you may like the Affordable Care Act or not, you may support it or not, but what I want you to come to realize is that although we're here to talk about what we can do and not what government can do, this is the list, and government actually got the list right. And what you'll see is Titles 1 and 2 are about health insurance. Title 3 is about health care delivery. Title 4 is about population and community health. And Title 5 is about the workforce. And you might question whether we can make huge progress nationally and regionally on all of these simultaneously. Or you might believe that we have to make progress on healthcare delivery and population health and reduce cost before we can expand coverage. All of those are perfectly legitimate debates. But folks, this is the list. There really is no doubt that this is the list. So my challenge is, how are you going to remember it? Now, because it's a large room, I'm doing this with slides. I typically do this with live props. This is Title 1. This is what the Affordable Care Act uses to address half the problems of health insurance. Half the problem of health insurance is a problem of insurability. There's folks in the community who are simply, under current circumstances, not insurable. They're not insurable because they have a serious disease. They're not insurable because they have a family member with a serious disease. So government uses a tool that uniquely is at its disposal, a magic wand. It waves a magic wand and says, you who are not currently insurable, guess what? Maybe I should say Shazam. Shazam, you are now insurable. And government does this. And you know what? Here's the strange thing. A lot of magic wands don't work. When I have a prop, I actually have one that does work. But a lot of magic wands don't work. This magic wand works. What makes this magic wand work? Well, I'm afraid it's the individual mandate. Everybody can be insurable if everybody is insured. And note that this is an image actually of a solution, because the problems associated with health insurance are the ones that are easiest to solve. So in addition to the health insurance problem of insurability, there's the health insurance problem of affordability. And the solution to that also exists and is in the Affordable Care Act. And it looks kind of like this. You'll notice there's some shape similarity to all of these images. In this case, it's a $100 bill. I usually only carry a 20. I don't know if I've had 100 in years. But it's really a stack of $100 bills, because as many of you probably know, in our current healthcare delivery system, a year's earnings at the minimum wage won't pay the family premium for health insurance in this country. So there's lots of people who are completely insurable. They just can't afford insurance. And so the other image of a solution is this image of the money. And that's Title II of the Affordable Care Act, and it accomplishes this, well, in Title I through some employee subsidies, and in Title II through a very large expansion of Medicaid, that because of Texas's very low baseline spending on adult Medicaid, will result over 10 years in a net influx to Texas of $67 billion. And that's from Susan Combs' report a year ago. That's not a number that I've invented. So these two are images of solutions. But then you have Title III, the delivery system, and Title IV, public health. And here I have to say, although the Affordable Care Act begins to articulate some approaches, we need to do a whole lot more, because the images associated with these are not images of solutions, they're the images of the problem. So let's talk about healthcare delivery. This is actually what I want you to remember about healthcare delivery. Okay. That's an ordinary ballpoint pen. I have one in my pocket, looks much the same. It costs about a penny to make. It also happens to be the most expensive medical technology in the world. Because pens like this, in the hands of hundreds of thousands of American physicians, are responsible for the spending of about $2 trillion in this country every year on everything from prescription drugs to specialty referrals to hospitalization to durable medical equipment and the like. And understanding the problem of the ballpoint pen is really critical to understanding both Title III of the Affordable Care Act and part of the real project that our community and every other one has in terms of improving the delivery of health care. So if there's one lesson to take away from this image of the ballpoint pen, is that when you talk about healthcare delivery, the technology isn't the problem. The technology is absolutely wonderful. The diagnostics are wonderful. The specialized skills are wonderful. The new drugs and devices are wonderful. The problem is the largely random way that we deploy all these technologies and the incredibly costly and productively inefficient way we deliver the services associated with the technologies. So by all means, let's innovate on the technologies, but we have to fix the problem of the ballpoint pen. And going along with the problem of the ballpoint pen, get the problem of the, all right, we'll go back one. There we go. Is the problem of the French fried potato. And this evolved in the talk from having my kids at one of the talks where I was waving the pen and noticed that they were at a dinner and they had French fries, and I reached over and took a French fry. So I would stand with a ballpoint pen in one hand and a French fry in the other. And so these are really the two twin problems of healthcare in this country, and the problems for our community as for every other community. Someone asked me this morning why I didn't bring French fries. The problem is that at this time of day, all you can get is hash browns. And they really don't work as well for the talk. And when I do this in the middle of the day or later, I do the full experience. Not only do I get the French fries from McDonald's, but I get them by going through the drive-through window. And I invariably eat several of them on the way over to the talk because they taste delicious. But these are the two problems. Title III is the healthcare delivery system. It's the ballpoint pen. Title IV is population health, and it's the problem of the French fry. It's the problem of health behaviors. And Eduardo is right. Smoking is still number one. Obesity and the things that flow from it are number two. Now, I like to do crossword puzzles. And a lot of the crosswords I do involve anagrams, scrambled words. So it occurred to me many years ago that indeed we all agree we want to keep Austin weird. And then it occurred to me that as part of technology, we also want to keep Austin wired. Here's something we don't want to do. We don't want to keep Austin wider. And here's the lesson about population health, and it's been said a couple of times, but let's just reinforce it. It's not an either-or between personal responsibility and community change. It's both together, and that's not my opinion, it's the science. And there was a wonderful issue of the journal Lancet about a month ago that went through this. It is the combination, as Eduardo said, about the enablers in the community that allow people's behaviors to improve. And then the image for the last of the 5 titles of the Affordable Care Act. The correct list of things that government gives us to do is people, and it's the workforce. And this is an incredible tool that we have at our disposal, and one we really have to take advantage of. I did come from the Northeast. I grew up in New York City, and I used to like to go to shows with my parents when I was a kid. And back in those days of paper, if you wanted a discounted ticket to a Broadway show, you went into a corner store and you picked up a little slip of paper which allowed you to get 2 tickets for the price of 1, and we called it a twofer. Well, investing in the healthcare workforce isn't just a twofer, it's a threefer. You get the skills you need to provide accessible care to the people you're now going to insure and care for. You get people who are involved for their careers and professions in healthcare who have a better sense of how to make themselves and their families healthier. And you have people who are better educated and working for a good wage and are economically productive and are healthier as a result. So there's nothing we could do better, in my view, than investing in the healthcare workforce. And so what I want to just leave you with, and now come over and hopefully with a microphone, begin to talk to our panel, is I want to talk about those problems of the ballpoint pen and the French fry, and I want to talk about the workforce, and let's see what everybody can offer. Thank you. Okay, folks, are we on here?
No, it's off. It's on?
The light's working, so it should pick up. There we go. Yay. Well, you know what? Can we start off with the problem of the French fry, the problem of health improvement and the problem of community improvement around health? And Ali, maybe you want to start us off and tell us a little about how you think of personal health and wellness and community health improvement.
Well, let me start off by describing my company so that I'll set up the parameters for what kind of human base we have. In our company, we have 19 people, and we carry health insurance. 90% of the health insurance is paid by the firm. The balance 10% is paid by our employees. And so it's a very fair system. So what we did is about 3 years ago, I realized that we, in our office, did not feel that we were heading in the right direction in terms of healthcare. We felt that there was not enough incentives we were giving our employees to keep better health. And so we started a program in which we started bringing in breakfast in the morning, and the breakfast and snacks. And all our snacks in our office, we started off with using like oatmeal and fruits, and we got rid of all the chocolate bars that we had in our office out the window and replaced them with granola bars and fruit bars and so on. So that was an incentive 3 years ago that we really pushed. And since then, the ball has been rolling pretty hard in our office. Most of our employees are health conscious. We do not have an obesity problem in our office. We have, out of 19 people, we have 1 smoker. And we are working with a program to see that. It's you. And that program really is, there's actually Seton Hospital has a very good program on there. We're going to be enrolling the gentleman in there. And so.
Is there anything that you think the community could do to help you in terms of what you've been experiencing in your own workplace?
Well, from the community point of view, yes. I mean, I'm not sure if the community directly can influence, but all around, when you're walking around in town, and when you are going to restaurants and so on, healthy food should be available. Austin is pretty good at that right now. It's slowly changing, but from our employees' point of view and all that, the way we see it is when an employee basically is working for the employer approximately more than 50% of his alert lifetime. In other words, basically, if you remove the sleeping time, you're left with the alert time. And there is an obligation on the employer to take care of their needs in terms of their health care, their well-being. And so I'll discuss with you more later, but we have some other great programs that we have implemented to increase the health. Community-wise, I think healthcare programs, insurance companies need to offer more incentives to small businesses to incorporate some wellness programs into their curriculum so that wellness of employees directly leads to productivity and profit.
Kathleen, Angel, how does this look like? What does this look like from the perspective of a large company like Dell?
Well, good morning, everyone. I just want to take a minute to thank Trish and people who convened this meeting today, because as I've been in healthcare for a long time in a variety of positions, and what I find is we all just talk to each other many times, and then we kind of get into a mindset of poor us, and a lot of people are feeling a little beleaguered right now, but also obviously optimistic to have this shared dialogue, so thank you. Actually, we have a particular success strategy around the French fry in particular. We have a more comprehensive health strategy, which I could talk about, and I'll share some thoughts about, but we have on-site cafeterias in many of our buildings in the Dell campus and around the globe. And we have implemented through our cafeteria vendor a pricing strategy. It doesn't necessarily have to be a subsidy strategy, but a pricing strategy where we make not only good food accessible and easy to get, low-fat mayonnaise, we call it stealth health, but we actually price the French fry and the cheeseburger, hamburger more expensively relative to the fruits and the vegetables and the salads. So it's a matter of having it there, putting the information out. We have signs showing calories. We have signage out that makes it appealing to go for healthy foods, and we price it differently. And we have found, we've only done the pricing strategy in the last 2 or 3 years, but as we've seen that, we've actually tracked the data and see that more people are eating healthier options. So, if you call them, they will come, kind of thing.
Eduardo, your company provides coverage to small workplaces like Khataw's and also to larger ones like Kathleen Angel's. What are you doing to help these accounts with their efforts to improve health?
Well, we certainly are talking the talk of the value of health. We are trying to connect those small employers with many of the wellness services that we provide. We have health coaches that help people with their lifestyle change issues, whether it's tobacco or weight. We have online programs that help people track what it is that they're doing or not doing. We certainly can point to ourselves, because much like Kathleen talked about with Dell, we've made some wholesale changes in our cafeterias where we are selling healthier foods. We've moved whole categories of food out and moved healthy food in. We've actually got a chef who's designed a 500-calorie lunch that includes everything with a dessert. And so if you eat that, you're good. We have gone into our more remote places and made the kinds of changes in vending machines that one would expect to be made. We did kind of a goofy thing this year, in my opinion, but it's been hugely successful. We committed as a corporation that includes the 4 health plans, Blue Cross Blue Shield, Texas, Illinois, New Mexico, and Oklahoma, to lose collectively 20 tons of weight. And we are on track to exceed that. And I thought it was a little bit goofy, but we are encouraging healthy weight loss. We are helping folks track what they eat. physical activity. We're rewarding people for that physical activity. 50 days of physical activity equals $50. Not a lot of money, but when you're OCD, you can get really kind of into tracking your stuff. Not that I'm confessing. And we are using that as a way to talk to small employers to try to figure out how you scale down what we're doing and make it work for a small employer. And we're absolutely trying to figure out how we can think of things in an aggregate so that the experience of one sick person in one small company doesn't turn into what has been the experience in the past of suddenly premiums go up so much that it becomes quite unaffordable for the company. So we are trying all kinds of ways to connect both the small business opportunity, the large business opportunity, and because we sell product to individuals, also how do you harness wellness and health on a kind of one-on-one basis.
Judge McDonald, maybe you could tell us a little, you're responsible for the welfare of a large number of individuals in Bastrop County, and perhaps you could tell us a little about what you've been working on at the community level and who your partners are.
Okay. First of all, I'm competitive, and I looked at the slide, and you had Bastrop out of the 5 counties. We were like the last county. Is that correct?
Of the ones I looked at.
That's the ones. So that's a challenge. So we are motivated in Bastrop County. One of the things, we are a retirement community, and we have older individuals in our workforce. So one of the things that we've changed, we do have a county gym now that is open to all our county employees. So therefore, because salaries are limited, we let all our county's employees be able to come and work out at our gym. Also, we're having a tracking mechanism when we're walking, keeping account of all the calories that we're taking, and we have a competition at the end of the month to see who would win that. And then also, we realize that it goes beyond just the physical walking, it's a mental aspect. So we have something called Power Hour. So every first Friday of the month, we bring all our employees and we have a motivational speaker to come in just to encourage them on how to deal with workplace stress or how to become a better employee. So those are some of the things that we're doing just at Bastrop County. But also, one of the things that we believe in Bastrop County, you have to market what you have. And we're a community where we still know each other. And you can still walk down the street and someone will ask, well, how you doing today, baby? We still have that type of deal. We do. I've been county judge for 13 years, but I'm still Willie McDonald's baby boy, so I understand that. Hey, and I walk in that. But one of the things that we want to encourage is just in educating individuals about health. I'm 40 years old now, and things are changing. I'm having friends who are passing away, so I understand the importance of that, and those are things that we're trying to push in our community.
Well, let's talk a little bit more about education since you brought it up. And you know, I've been doing health policy work now for a couple of decades, and I'd always really thought that I was working on this to make healthcare better. And then I came down here and I met people like Eduardo, and I started to really work more on health than on healthcare, and so I'm converted to the public health cause. And then one day, as I was sort of looking at the state budgeting challenges, not just in Texas, but nationally. And I looked at what I thought was just a horrible situation where two things I care deeply about, healthcare and education, seem to be competing for the same pot of money. Mm-hmm. I realized that what I'm really doing isn't trying to make healthcare better for healthcare, it's really trying to make healthcare better for the sake of education. So maybe, Susan Dawson, you could tell us a little about what you've come to believe and understand about the relationship between education and health.
You're absolutely right, Bill, and we've heard it today, how health and healthy communities are inexorably linked with so many other pieces of our systemic needs and systemic infrastructure, but I think education is the strongest. And we talked a little bit about demographics, but let me bring it home some. The student population of the state of Texas over the last decade grew by 21%. That's far and away the fastest state of all 50 states. The student population here in Central Texas grew at 40%, twice that rate. Our low-income students grew at twice that rate. So our poorest students here in this region are growing at twice the rate that's already twice the rate that's the fastest in the entire country. What we have is a huge population of kids coming into schools that have heard very few words at home, don't in many cases even own a book, have never held a crayon, are not ready to enter kindergarten to be successful in school. And what happens, just like every kid, they go to school, they get sick. The ones who are the poorest among our population often don't have primary care. They don't have insurance, you've seen that. And so they are the ones that miss more days of school, that are going to the emergency room when they don't need to. Precisely the ones that need the most access to education are not in their seats in education enough to be able to close those achievement gaps. Then if you look at the other end of the spectrum, we've got, use whatever name that you want to use, we've got roughly a third of our students dropping out. Some of them because of disadvantaged backgrounds, many of them just because they were bored or unchallenged or had social issues at home. But those that drop out are the ones with the highest instance of smoking. They're the highest instance of interacting with the juvenile justice system. They're the most likely to become obese. They're the most likely to develop diabetes. Any factor in health is related directly to the educational attainment of those students. So what we see is that you either have this vicious cycle downward of education driving poor health and vice versa, or we build a virtuous cycle. And that's what we have to do, is look at education and health being inexorably linked.
So if I could ask either Ali or Kathleen to respond first and then maybe pass it to the other. What can the business community do? How does the business community kind of listen to that and think of ways to respond?
I'm going to answer a different question. It's like dealing with the newspaper, but only in the sense that when I was sitting here thinking about education, I can't speak to really the education of our children. What I can think of is a couple of observations I have about education in the community, and that's one of the things that the St. David's Foundation, I sit on the board of, has been instrumental in founding a scholarship for the Neil Kosurik, memory of Neil Kosurik, that is scholarships that are going to foster education in the healthcare industry. So when you think about the healthcare workers of the future who are going to interact and support all that we're talking about at a variety of functionalities, we've got to ensure that workforce is coming forward. When I think about education, I think about consumer information from where I sit and trying to help my employees and their families. It's really about them being empowered as consumers to have the information they need to make the decisions they need, which makes it really important for information to be transparent and at a consumer level. Of course, that in turn, we don't think of our team members as just individuals who come to work and are productive for us. We think of them as spouses, as family members, as parents. So in turn, they're going back and translating a lot of things we're talking about to the younger population that I think you're talking about in the strictest sense of the word education. So,
Ali?
Health education and health lifestyle. Education, schools, institutions are they play a very major role. But I think it also starts from home. There is I think a kid going to school is in that environment. But when he comes back home, it's what kind of food does he get? What kind of diet does he get? What kind of advice does he get from his parents? And so I think there's a big role of educating. And of course, the education of the parents can be directly related to the workforce and the corporations. I think corporations need to take a very hard line in terms of realizing that it is about time they stepped up and increased their healthcare programs, wellness programs in their offices.
But if I may, Ali, it is certainly what happens at home, but it's also what we do from a policy standpoint, from a physical infrastructure. So I was speaking a couple of weeks ago with the superintendent and administrators of Del Valle ISD. Del Valle is 164 square miles. It's one of the poorest areas in the Central Texas community. Many of their students and families don't have cars, don't have accessible transportation. They bike or they walk, and they cannot get to a place that has healthy food. The only place that they can get to is a Dollar General with Beanie Weenies. They told me that in the 164 square miles, there is not a single physical space for healthcare. There is not a physician's office, there is not a pediatrician's office, there is nothing. So if we don't have the infrastructure for those families to be able to access, it's very hard for them to build this kind of healthy lifestyle.
Eduardo?
I think there's a number of things that employers can be doing. One is to understand the link between education, health, and their bottom line. whether it's directly the employees. For large employees, I dare say at Dell, there are folks who live in a variety of settings in the Central Texas area, some of which have superlative school systems, and there's a degree of affluence that's going to guarantee some things, and some who maybe don't. And so the notion of trying to raise the bar and reduce some of that variability, whether it's about access to food, performance of the schools, access to basic primary care, I would argue access to public health services. I think the evidence is fairly compelling. There is a role for business to play. The other thing is that businesses are paying the medical claims for children. And fit kids are smart kids. Not fit kids are using the medical care delivery system more than fit kids are. Not to the degree that adults do by any stretch of the imagination, but the investment at the school to promote health is a very, very inexpensive way to link up the fit kids are smart kids. One other thing to the point that Ali made, there is some evidence, some of the work that's come out of the coordinated approach to child health, which some of the school districts in this area have adopted, is that you can use the schools to help bring information as messengers to the home. We have to figure out ways to get into the home setting in those lower income communities. Students are one way, community lay health workers are a different way of getting basic healthy lifestyle, daily living kinds of lessons into the home. And I see one employer here, one retailer. The other thing we've got to figure out is we can talk about healthy foods, but folks have lost the art of knowing A, what the healthy food looks like, and B, how to prepare it when it's in their hands. And so part of education is also retraining ourselves how to eat healthy, how to be healthy. The role of corporate Central Texas is to understand the link back to the bottom line and push, because corporate Central Texas really are the ones who can influence the so-called decision makers, the people who are in elected positions, in ways that grassroots sometimes are not able to do. There is a role to be played, and this discussion begins that shared education that can result in the kind of conversations that can make a difference in terms of policy, because at the end of the day, policy is what's going to make it easier to make it happen.
Judge?
And I want to talk about this, because I think it's the commitment that you have. As y'all know, Bastrop just went through a fire. Most of y'all know that. And one of the things I saw in dealing with an emergency is how all the pieces come together. We were a small community, but I saw resources from around the region coming to help us be successful. And as I was sitting back there watching that, I was in amazement, because I realized Bastrop as itself couldn't handle that situation. But when all those pieces came together and all of the resources came together, it benefited our community, and it continues to benefit our community. I think the same thing comes in health. How do we all come together to address this problem? How important is it? How do we set a plan out to make sure all the pieces come together to work with it? So it's about our commitment, because we don't have all the resources. Our communities don't have it, but I think everything we need is in the body. Everything that we need in the community is there, and we've seen that in handling disaster. And I also want to say this, it's about marketing. My kids don't just like the way McDonald's tastes. They don't. They don't go and say, man, that's the best cheeseburger I ever tasted. But McDonald's does a great job in marketing. Yeah. So when they see those little toys and all that, say, I want to go to McDonald's. They may not even eat the food, but it's the marketing piece. And I think even here in Austin, the reason it's so healthy is you have UT. And UT is right down the street, and people are running, and they're doing, and it sets a climate or an atmosphere saying, hey, I want to be healthy. And as you move away from that, as you said, education and all those, but it's a mindset that is set. So you have to go forth and continue to set that mindset, to set that goal of saying this is where we want to be, and this is how we work together to achieve that and have all of the pieces together. Now, how does that work? Switch another hat. In government, when it comes to businesses coming into our communities, how are we pushing those initiatives? How do we tie health, working with our schools, all those things to initiatives that are going to want to make businesses and companies be a part of that vision? So it has to be, I believe, a community vision that goes from the top all the way down.
I think we want to open this up to audience questions, but I do want to just spend a minute talking a bit about the problem of the ballpoint pen from the problem of the French fry. And that means, sort of innovation in healthcare. And, Eduardo and I on this panel, and Kathleen, have done this for a long time. Some of the rest of you haven't really done it as much. But I think, Senator Watson set out this really kind of bold and exciting vision of academic medicine in Central Texas and all the things that go with it. But, speaking for myself, I really want that to be not just the innovation that Eduardo referred to, where the price keeps going up and the cost keeps going up, but the performance really doesn't seem to. I want it to be kind of innovation that really makes things better and, frankly, does it less expensively. What are some pieces of advice you might have, even kind of tentative pieces of advice for all the kind of healthcare folks and academic folks who are in the audience and the community about how to do this right?
Well, I'll jump in with a silly idea. I was reviewing the full paper, not just the executive summary, but it's in the executive summary, the huge cost of unwarranted care. It's basically $300 billion. And going back to the education theme, the way that we interact with doctors today is very different than it was 15 years ago. People have already researched their disease. They know what the possible treatments are. They come in having educated themselves when they have a discussion with their healthcare provider. I wonder if we couldn't take our community and develop the education to say, where is the waste? Where is the unwanted care? Do I really need this procedure? Because if we took a part of that $300 billion and put it back into insuring more and driving more innovation, that's a pretty big chunk of dollars.
Anything,
and
Kathleen?
I'm not saying this because I'm sitting here having working for Dell, because I'm in HR, so I'm not a computer expert. But I've been saying this for years, it's technology. A part of this is looking for the opportunities of technology that can add to administrative efficiency, to the patient experience, and to the way in which we access care, telemedicine, and the way in which physicians deliver care. And for any of you who have been involved in putting in an information system or changing out an information system in your own companies or supporting it, it starts with problem identification, looking at opportunity. But the biggest risk you have is that you will implement the new information system on the old process. And I think we have a huge opportunity here for process reengineering if we can work across our stovepipes to understand where our common interests are, perhaps where we have some common guidelines, and look for opportunities to eliminate the waste, but really process reengineer. There have been Medicare demonstration projects for these accountable care organizations, and unfortunately they have not proved to be cost effective, and I do think cost is the number one problem that will allow us to use our resources differently. They have not proven to be. They have been very innovative, and they've shown some very good examples, but unless we go into creating these new mechanisms that may be empowered by the new legislation with the idea that we're going to be more efficient, pay for the right care, not waste care, and have it at an affordable price, we're just going to be collectively putting together old paradigms and keep the costs going up. So I think reengineering and looking for technological opportunities for efficiency and better quality care.
Eduardo.
I heard someone yesterday describe comments that were made by U.V. Reinhardt, who's the health economist, that if the conversations that we're having result in aggregation instead of integration and innovation, all we're going to do is add cost. We haven't done anything new. We've just sort of lumped things differently. A couple of things. One, I completely agree that transformation of how things get done is the key. There's no question that physicians know how to diagnose and treat diabetes as it relates to the knowledge acquired in medical school and continually acquired in medical education. What's the number that says that someone has diabetes? What are the medications that we ought to use? What physicians don't know how to do is how to organize their team in a way that maximizes the use of that team to address a population of people that have a set of medical problems. They know how to make the diagnosis, they know how to write the prescription, but they don't know how to organize themselves best. And so in this world of ACOs, I think part of the reason why ACOs, accountable care organizations, haven't necessarily worked is because they've aggregated and not really innovated processes. And in this world of patient-centered medical home, we've learned that, and I'm so pleased to see Blue Cross Blue Shield of Texas actually mentioned as one of the partners with ARC on a patient-centered medical home pilot. What we've learned is that while people want to be called medical homes, they want to be medical homes, they don't really have the systems in place to do it in a very effective way. So the other thing, not only innovation in terms of technology, there are others that are beginning to think about bringing industrial engineers. Those are people who learn all about systems. If you've ever seen sort of an industrial engineer's curriculum, it's all about lines and boxes and triangles and squares and circles, and they all mean something. I'm not smart enough to know what it is, but we need that kind of expertise and consultation to take these really complicated ideas, not just about medical care delivery, but about schools and about government and about the small workplace, and begin applying some industrial engineering techniques to systems analysis to help us figure out not only how to do it, but how to measure it and how to improve on it as we go along. Man, I got really way too excited about that. Sorry.
Kathleen wants to add one
I
thing.
just want to pick up on that. I should have mentioned it, but you inspired me to do so, is health information exchange. You know, it's not just enabling the processes, but getting the information exchange so that physicians and providers of care can operate on that at a level playing field and get it out to the public so that information is transparent. I think that's another aspect of technology that we're just beginning to tap.
Yeah. And I want to strongly agree with Eduardo, but also say he's too modest. You may not know that in addition to his other accomplishments, Eduardo actually has a master's degree in biomedical engineering from Duke University. So he is smart enough to understand how these things work. We're going to go over to audience questions, but forgive me, I really need to say something that's important to me since we're here in this room together. I'm very excited about the prospect of expanded academic medicine in this community, and I'm really excited about the way in which we can all innovate and improve health and healthcare. But it's just important to me to be able to say to you that I think as we build this very kind of inventive and creative process, we have to make sure that we don't just look west of IH-35, but we also look east of IH-35. That we really look to some of the poorer members of our community and make sure that what we're doing serves them as well as serving us. So with that, let's open it up to the audience. I'll hand this to whoever wants to manage it.
There's one back there.
There's one.
Hi. Good morning. I'm Angela Atwood with Family Elder Care, and I wanted to ask the group, given that the Austin Round Rock metropolitan area has the fastest growing older adult population in the country now, third fastest 65 and older, what do you think are the key things we can do as a region to really develop our capacity to serve and support older adults and caregivers?
Well, since everyone's jumping in, obviously workforce is an issue. I think understanding that, I think the evidence suggests that folks who are at home and or a home-like environment do better than in some of the, what we think of traditionally as being kind of the nursing home environment. I do think that the evidence is very, very compelling that living a healthy lifestyle as a child, as an adolescent, as an adult, as a middle adult, and as a senior all contribute to better health later on in life. And so the degree to which, as the conversation is had about access to healthy food, about physical activity, that we keep in mind
now that I have to wear readers, I'm very aware that life's different now than it was before, that we keep in mind that whatever we do, we make it the kind of place that is welcoming and accommodating to seniors. That may be a very simplistic answer, but I think in spirit, that's the attitude that we've got to take. And I'll say to you, when I visit Austin on Saturdays and Sundays, I go to the hike and bike trail. I love going there. It is a place that if we could figure out, if Central Texas could figure out how to migrate some of that to the other counties, and that's that spirit on a Saturday morning where you see old people, young people, small people, big people, people with walkers, people being pushed in chairs, kids being pushed in strollers, dogs, bicycles, all of it accommodated in this area that is all about people enjoying the outdoors and being physically active. It is welcoming to all, and it says, come and move your body and be a part of this. That's the spirit with which we need to think about seniors. We need to understand demographics are beginning to shift around as well, and be sure that we address the fact that it's not just white folks, there's African Americans, and among the seniors particularly, Latinos are less likely to be as conversant in English as maybe the younger populations are.
Judge?
I think also what we've seen in the rural communities is you have to have connectivity. You have to have your senior population connected to the community. And that means for transportation, being able to access medical care. You have to have individuals that, and one of the things that we don't have a transit system. We work with carts, but sometimes when it comes to the seniors being able to get to the doctor's office, get to their appointments, get to the places where they're going to get the healthy foods, you need a network that's going to be associated with them that is going to be able to take them to those different places. So it's important for us as churches, businesses, civic clubs, how do you work with the individuals who are going through? I always say this, when somebody gets sick, people will be there for the first week or so, how can we help you? But if it's a long-term illness, you would see individuals drop off. So we have to have individuals that are assigned to make sure that Miss Wilhelm or Miss Smith is getting to their appointments, and someone is going in and talking to them, communicating with them, and letting them know that they're still part of the community and we love you and you care. In the rural communities, I think that's important. Now we do have Seton and we do have St. David's coming in, but before that we always had to go into Austin. So you have to have transportation networks set up to be able to go with those seniors to have them be a part of the community.
Okay.
Another question?
I would also hope that if we develop, or when we develop our medical school, that we encourage people to look at geriatrics and specializations in gerontology. We have a real shortage of healthcare professionals who know how to work effectively with seniors. Thank you.
Could I comment on one aspect of that?
Why don't we ask one question?
Okay,
and we can
that's fine.
put it together.
Yeah.
Andy Miller, I'm with Livestrong, Lance Armstrong Foundation, and this is somewhat related to Angela's question. I've seen a lot of this data in a multitude of different presentations, and I actually just came from one where it was presented in looking at the opportunity that investing in palliative care services and how that could help potentially bend some of this cost curve, especially as you look at diseases like cancer, COPD, things that have increasingly expensive per capita costs associated with them, as well as oftentimes results in accessing very expensive care like emergency room care when symptoms and side effects aren't well managed, ICU admits at the end of life that may not be necessary. Talk a little bit about kind of the balance in terms of where you see us investing kind of our resources in terms of creating services, creating workforce that help address not just care that's going to extend our life, but also actually improve the quality of life that all of us hope to experience, because it oftentimes is something that's not mutually exclusive, but it's thought of that way.
Kathleen, do you want to start here?
Well, I was going to, thinking about the elder care issue, let me just say one quick thing and then come over to this, is that I really think any of us as civic leaders or even members of AARP, we need to influence Medicare and what's going on in CMS right now. We know that's in the news a lot and it's being threatened, but also there is a lot of innovation and openness in the CMS leadership right now. Anything you can do, they're writing regs, it's happening now, influence that. And then going back to your point, I mean, I think thinking about end-to-end opportunities for steerage of anywhere where you can have to influence people to get into the right situs of care at the right time and get the right care is extremely important. If I can come back to staying healthy and thinking across the spectrum of areas that we can influence here, our strategy for maintaining health has really been fairly comprehensive and has evolved over the years, but it's outcomes-based now. It's based on CDC, and we are holding people accountable in order to get financial incentives to have less than a 30 BMI, to exercise more than 150 minutes a week, to have blood pressure under 140 and 90, and to be tobacco-free, and our campuses are tobacco-free. So we're trying to move the bar of accountability and therefore incentivize people to be rewarded for outcomes as opposed to just participation, which I know, philosophically is very much in keeping with you have to walk the talk and then get the involvement in the program. So.
I think we should take one more question from the audience and then do tabletop conversations.
Can I just add real quickly to it, Andy? Andy, I think yours is a very important question. This series and this dialogue that Central Health has started, I think if I was going to advise something, it would be bring this into this conversation. It is a very, very important thing that sometimes doesn't get included in the discussion, and yet it really ultimately is an issue that has to be had at a community level. Remember, when this conversation was had before, it devolved into death panels, and so it has to be done in a very, very thoughtful way and start with conversation and not with someone with a policy idea that then turns into just a bad soundbite. But I think it's very, very important to pursue and explore.
Hi, I guess I'm lucky I have the microphone. My name's Tricia Forbes, and I'm the Executive Director of the Sims Foundation. And one of your statistics addressed mental illness, but we know that our systems here in Texas and even in Austin are very problematic, and to get psychiatric care in this community is very difficult, and the costs are astronomical. And so I would just like to hear where you think prevention and treatment of mental health care comes into all of this.
I'll try to be really short on this. I served as Commissioner of Health for the state of Texas. My first job was at TDH. My second job included the mental health system. I had to learn a whole lot about mental health as a system. I'm a family physician first, and I knew and I learned as a family physician that a lot of stuff that gets diagnosed as mental illness presents in the primary care setting. I am committed in the place I'm at now, in the place I was at before, into very, very carefully exploring the integration of mental health and behavioral health services into primary care. There's a challenge, though. I'm not sure that the system is ready to embrace that. The capacity, the competence, and the confidence doesn't exist. There are places like People's Community Clinic, the community clinics here in town. They have figured it out. The Lone Star Circle of Care has started doing that. They are models for what should be happening all across the state in private settings as well as more public settings. And so I think that you've got in this community and around this particular initiative, the three models that are working that could serve to inform how it might get done in the other counties outside of Travis and Williamson County.
Maybe one more comment on the mental health side. Judge, perhaps?
Well, I was going to echo what you said, because I think we've got some great models in the community. And just an observation, this is so underdiagnosed and undiagnosed. And I happen to be with a group of people this week who do what I do for a living, and we were commenting on the fact that just what's going on in the economy, what's going on in our nation, never mind whether people are working hard, everyone is very stressed. And we need to think about stress and mental health as perhaps being barriers to a lot of the things that we talked about wanting to accomplish today.
Absolutely.
You know, before someone can think about eating healthy,
Absolutely.
exercising, they have to be ready to deal with it. So
That's absolutely the case. The comorbidity between depression in particular and chronic diseases, the ones that were on that list, higher than you would expect, and to the point. To think that a person with diabetes or high blood pressure, whatever it is going to be with the program when they're not in a place where they are motivated to even get out of bed is a real challenge. One thing, I saw David Evans, and he will kick me, but the MHMRs and the MHMR system does a yeoman's job with less than adequate resources, but I believe that we need to figure out partnerships that bring MHMR, primary care, health plans need to play a role. All of us need to play a role in bringing that stuff together. One other thing for employers, this is important, EAP. Your EAP programs are part of that system, and figuring out how to make it more integrated rather than just aggregated is a way to get to that place that you were talking about with your question.
And now we're actually at the most important part of the morning.
Yes.
Because thanks to Central Health and Arrow and many others, we'll have many opportunities over the next year to talk about these issues. But it's time for all of you to contribute to today's conversation. All of us here on the podium understand that by far the majority of the expertise in this room is down there at the tables. So you all now have an opportunity to talk about some of these things. Please remember the ballpoint pen and the French fry, and come up with what you think should be either the answers or, at this point, even the questions. So let's work for the remainder of the morning.
Thank you. You know, Yui was my economics professor.
Oh, is that right?